we move on to some patellar instability, and if you guys think of other stuff, feel free to ask at any point. So again, we're going to just start off with a bit of epidemiology. So patellar instability is relatively common, an incidence of about 7 in 100,000. And this definitely increases as the population is younger. So up to about 43 per 100,000 in a younger population. We actually often see patients coming in with their first instability episode around the age of 13. So it's quite young. And then there's a ton of patients who have ongoing instability or pain. And then the recurrence of it after a first-time dislocation is anywhere between 15 to 44%. And the reason why that number is so varied is that each patient that comes in with patellar instability is not just patellar instability. It's not just one diagnosis. There's a ton of different factors that contribute to that instability of the kneecap that make it very complicated. And so these numbers can vary quite a bit. And so that leads me to my next part is, well, what is patellar instability? And I think it's an important thing to try to define because, you know, it's not just a kneecap dislocation. It's not just those patients that come in and say, yeah, my kneecap dislocated and someone had to put it back in. That's not what patellar instability only is. It's part of it, but it's not the only thing. There's lots of patients that come in and say, you know, my kneecap feels unstable. I feel like it's going out, but I've never had a full dislocation. That's also part of patellar instability. And so there's multiple different factors that lead to this instability that makes it a lot harder to diagnose and a lot harder to define compared to, let's say, an ACL tear. So again, just a little bit of anatomy. And, you know, when it comes to anatomy for patellar instability, like I was saying, because it's so multifactorial, it's not just one ligament. It's not just one structure in the knee that leads to that instability. So the main thing that people think about when they think about patellar instability is that MPFL ligament. So the medial patellofemoral ligament. It's a structure that originates on the patella and then goes and inserts on the femur. And it helps to prevent lateral displacement of that patella. And when that patella goes out, it most frequently wants to go out laterally. It's very rare for it to want to go out medially, even though sometimes patients come in and say, I am 100% sure my kneecap went medially. But what they're seeing is actually the medial femoral condyle while that patella is out. That's what they're seeing, that like round structure that they think is their patella that's gone out medially. Other things that are super important when it comes to patellar instability is looking at different type of structures around the knee. So one thing is looking at the height of the patella. So is the patella high or low in relation to where we think it should be? And the reason why that's important is that if a patella is really high, it's not actually articulating or making contact with the groove of the femur, or what we call the trochlea. And if it's not making contact with that trochlea, then it's not getting the stability that it wants or that it needs as the knee goes into flexion. And then the other thing, one of the other things that we look at is something called the trochlear groove and, or what we call the TTTG. So the trochlear groove and the tibial tubercle. And basically what that is a relationship between that groove of the femur and where the tibial tubercle lies on the tibia. So that's that nubbin of bone that's a little bit more prominent around the knee joint on the tibia. And that gives us some information about how much that kneecap is trying to be pulled out to the outside of the leg, so out laterally. And then also we look at the trochlea itself. There's some people who have what we call a deficient trochlea. So it's not very deep, it's not very pronounced. And so if it's more of just a flat structure, again, as the knee goes into flexion, that kneecap is not able to sit anywhere. And so it has more ability to move laterally because there's no groove for it to sit in. And then we look at, you know, what we call femoral anteversion, which is just twisting or rotation of the femur or rotation of the tibia. And all those things together can lead to this patellar instability. And it can be very difficult to figure out what's causing the patellar instability in any given patient. So again, we look at mechanism of injury. And so, like I was saying before, You know, when it comes to ACLs, it's much more standard to get a typical story, some type of pivoting injury. They often feel that pop, that swelling. But when it comes to patellar instability, it's not near as straightforward. Definitely, it's most common to have a patellar dislocation when the knee is fully extended, because again, like I was saying, that patella is not engaged in the trochlea, in that groove of the femur where it's more stable. So in that fully extended period position, the kneecap can go out laterally. So that's definitely the most common one. And then the other thing that we do often see is some type of contact. So this you could see more in football or rugby, where there's contact sports and someone gets a direct blow to the knee and the kneecap pops out. So if we go over typical symptoms again, pretty similar in many ways to the ACL, you know, pain, swelling, and then the other thing is looking down and seeing that your kneecap is out to the outside. And so here you can see that the kneecap is out to the outside, and patients will look down and see that. And we often ask them if they have ever seen that. It just helps us to confirm that a full dislocation has happened in the past. And then the other thing that they often have, like I said, is the swelling. And swelling can again be multifactorial, but one of the things that we don't want to miss when it comes to a patellar dislocation with a ton of swelling or a big hemarthrosis is that they haven't done damage to the cartilage of either the femoral condyle or the patella, because sometimes they can rip off a big chunk of bone, which is what we call an osteochondral fracture, and that has to be fixed acutely. It shouldn't be left alone. It shouldn't just be left to float in the knee, because it can often be a pretty big chunk that if it doesn't get addressed immediately or very soon, it's never going to go back. And then during recovery, you know, the symptoms that people have is just that their kneecap feels unstable. It feels like it's always wanting to go out. But again, the stories that people tell are not always as consistent as you would like them to be. So in terms of initial treatment, so again, coaches, athletic therapists, or physios who are on the field with them, the most important thing is if you do have a true dislocation is trying to get that kneecap back in as soon as possible. This can even be done on the field if you're comfortable with it, but the easiest position to do that in is try to get the knee out into full extension, and then it can come back in a lot easier. You can't really reduce the patella when the knee is flexed. It's just not going to go. All the structures are too tight, and so you need to get that knee out straight before being able to put it back in. In some cases, the patient has to go to the emergency department and get some sedation before it's able to go back in. And then from there, it's pretty similar to the ACL. So working on that RICE protocol, making sure you're getting good range of motion, you're getting rid of your swelling, and specifically with patellar instability is working on that VMO, so that vastus medialis muscle, trying to strengthen it, because a lot of patients with patellar instability are just lacking in that muscle. They have much more defined lateral muscle, but their medial side is weak and it's not able to help keep that patella on the medial side. The lateral side is too strong and pulling that patella out laterally. So working on that muscle is important. Unfortunately, it's very difficult to develop. There almost seems to be a developmental or a congenital component to it that prevents them from getting super strong muscles. That being said, the patients who have more of a contact type injury, they actually tend to have pretty good muscles, and they tend to be a little bit of a different kettle of fish than those who have your chronic type patellar instability. Those are the ones that we see who have more atrophy of that VMO. And then the next thing you know is getting your referral to your sports med doc, and then possibly getting a referral to the orthopedic surgeon. So again, when it comes to diagnosis, we always start with our history and physical. And like I've stressed multiple times, the history on this is not as clear. And so that usually requires a little bit more digging before we're able to figure out what exactly is going on. The other thing to always ask about is whether or not they are like super stretchy people. So there are certain conditions like Ehlers-Danlos syndrome that can lead to much easier dislocation. So their body structures, their ligaments in general are just so much looser than a normal structure in people who do not have Ehlers-Danlos syndrome. And so they are people that we take extra precautions for, because we know that their risk of redislocation or re-injury even after surgery is much higher than normal. And then in terms of physical exam, it's very similar again to the ACL. We're looking at that muscle bulk, specifically that VMO, and then we're looking at apprehension. So what is apprehension? It's a good question. So basically what you're trying to do is see whether or not the patient is uncomfortable when you're starting to push that patella out laterally. And so this is done at 0 and at 30 degrees. At 0 degrees, like I was saying before, that patella is not engaged in the trochlea. So there's no bony structure to help keep that patella engaged. And so you can see if they have apprehension, and they often do. Then you want to do it again at 30, because at that point, the patella should be engaged in the trochlea and the bony structure should be giving some stability. So you should have much less lateral instability at that point. The one time that they don't have that, or two of the times that they don't have that, is when they do not have an appropriate trochlea. So their groove is not well defined and it's much flatter. And so they can still have lateral translation of that patella, or if they have patella alta, which means that they have a high riding patella. And so at 30 degrees, they're not actually engaging the groove yet because their patella is still floating above the groove. And so you might still have some lateral translation at that point. And then the last thing is the J sign. And so I want to see if this works. Yes. Okay. So this is a J sign, and a pretty good one. So you see the kneecap is going straight up and then it kicks out laterally. And so that's what we call the J sign. So that's one of the things that we look for on our exams. In terms of diagnosis, so it's a little bit more complicated when it comes to patellar instability compared to ACLs. We get an X-ray for ACLs for sure, and then sometimes we get an MRI. But when it comes to patellar instability, every single patient gets X-rays for sure. There's a bunch of things that we look on for X-rays, and then everyone gets either a CT or an MRI. The reason why we're getting at CT scan is we want to look at some of the bony anatomy. So one, we can have a look at the trochlea. So this is that groove that we were chatting about here. This is a CT scan. And it's what we call an axial view. So if you imagine that someone is lying down and you're looking from the bottom up, so like their feet up to their head, this is a cut through the knee. This is the front, so this is their kneecap, and this is their femur. This is the back of the femur, and this is the front. So this is their trochlea, the little groove. And as we scroll through the images, we can get a better understanding of how deep or shallow that groove is, or what we call dysplastic, which basically means that it's not normal. We get a better idea of what that groove is. We can also look at how much tilt there is in the patella. So the patella gets tilted over laterally, so to the outside, and that's because of much tighter structures on the outside of the knee. And that gives us an idea of whether or not we have to release some of those structures to let that kneecap sit back in the groove. And then the other thing we look at with the CT scan is that TTTG number that I was talking to you guys about. And so you're measuring a distance between the tibial tubercle, this is just an overlying image of what the tibia would look like. And this would be the tibial tubercle here. So measuring a distance between there and your groove. And if it's high enough, then we actually go and cut that little bit of tibial tubercle nubbin off, and we move it over medially to get rid of that lateral pull. And basically, a lot of the surgery that we do is to get rid of that lateral pull to bring it back more in line so that we have proper tracking of the patella in the groove. The MRI is also useful for us, more useful when we're concerned about an osteochondral fracture. So if that patella when it dislocated, it knocked off a big piece of bone with cartilage, or just cartilage. Because if it's just cartilage, then we actually can't see it on X-ray. If there's bone associated with it, then we do see it on X-ray, but this gives us a much better idea of how big it is, where it came from, and if there's any other injuries in the knee. But it's not imperative to get an MRI for every single patellar dislocation, unless you have a big hunch that they might have done more damage to it. So like very large hemarthrosis, then getting an MRI is a good idea. In terms of treatment, so our usual algorithm is if you've had 2 or more dislocations, then you are candidate for surgery. That being said, like I said before, not every single patient has a full dislocation. So you'd be excluding a ton of patients who are actually quite eligible for surgery. So that's where the second part of the eligible criteria comes in, where those who are no longer functioning due to their patellar instability. And that could be people who are just having chronic instability of their patella, where it's not fully going out, but it's going out enough that it's causing pain and they're not able to do the activities that they want to be doing. And so those patients are also surgical candidates. In terms of treatment, so like I was saying, there's just so many different anatomic components to patellar instability that it's not just one surgery for all patients. There's a variety of different surgeries that we can do, and it totally depends on how the patient presents, what their anatomy is, and what's contributing to their patellar instability. The one thing that every patient gets is an MPFL reconstruction. So that's that ligament that we were chatting about before that originates on the patella and then inserts onto the femur. And so in order to do that, we usually take just one of the tendons of the hamstring, so a little incision on the front of the knee, and we take one of the tendons and we reconstruct a ligament. So this is what that ligament would look like. We then plug it into the patella, and it's a broad insertion on the proximal third of the patella. That's where we insert it. And then we plug it into the femur between the adductor tubercle and the medial epicondyle. And that's where the MPFL wants to live on a normal basis. That's its anatomic position. So everybody gets one of those procedures. In terms of the other procedures, so whether or not we release the outside structures of the knee, or whether or not we cut that nubbin of bone, the tibial tubercle, and move it over, or if we actually go to deepen the groove of the trochlea, that all depends on the patient, whether or not it's indicated or not. And there's different things that we look at to make those decisions. I wish that there was a really straightforward algorithm that we could just follow, but unfortunately there's not. It's actually pretty complicated in terms of the thought process. One, they need to have the anatomic problem to deal with it. And two, that they need to be of the right age. They need to be doing, like, we have to look at their function and everything else. There's lots of different factors that come into that decision making. Which makes it hard for the surgeon and for the learner trying to figure out which surgeries to do. And then in terms of rehab, so very similar to ACL in terms of our actual protocol. The biggest differences are, one, postoperatively, patellar instability patients get a brace. So it's a hinged knee brace. They're still able to do weight bearing as tolerated. They're still able to do range of motion as tolerated, but we brace the leg because of the quads inhibition. They just have so much more quads inhibition than the ACLs, and it takes so much longer for them to get it back. The other thing that we notice with these patellar instability patients is that their recovery tends to be longer. So today we saw a patient at 6 months who was an MPFL with a tibial tubercle osteotomy. And she was the only patellar instability patient we saw today compared to all the ACLs that were also at 6 months. And the ACLs, there's a little bit of variation between all of them, but they're all doing pretty well. Whereas the MPFLs, they take longer to get better. And I think a big part of it is that a lot of these patients have been living with patellar instability for years upon years, and they have to retrain their brains to think that, okay, I can trust my knee. Because we were testing her today and her kneecap, she's like, no, I really don't feel like it's going to go out. I'm not worried that it's going to dislocate, but she had to retrain her brain to believe that. She couldn't quite believe that her knee was stable because they had lived with it for so long. And I think that's a really hard part of the patient recovery that we don't talk about enough. And then in terms of return to sport, again, it's super variable. I find the ACLs, especially in the young population, like we were saying before, tend to be a very athletic group, whereas the patellar instability patients are a little bit more variable. You certainly do get those patients who are super athletic, and I think that those are often the patients who have more of that acute, full out dislocation. It's been the first time they might be a teen, they might be their young 20s. But really the only problem is that they dislocated their patella. In contrast, you have the patients who have, not a normal trochlea, they have rotational problems, their patella is just unstable, but it's never fully dislocated. Those are patients who might not have actually really gotten into sport in the first place because they've been dealing with this the time they were 12, 13, when they should be getting into sports in the first place. And they just never really felt comfortable because their knee, they couldn't trust it and it was painful. And so this is a little bit harder to say who returns the same level of sport, because I think the population who has patellar instability is just so much more varied. The one thing I think is important though, and I wish we had more of it, is that some of these patients probably need to be working with a sports psychologist, like I was saying before, or having just a really good coach, athletic therapist, or physio who can work with them and really get them to learn to trust their knee again. But I think it takes a lot of diligent time and effort, both on the patient's part and the coach or physio or whoever's working with them. It's not an easy road, and it definitely takes time. And that's all I got for you. So if you have any questions, I'd be happy to answer them.
We have a question on the chat from Stan, and he's asking what brand and type of brace for patellar instabilities do you recommend?
So the bracing that people tend to use is some type of patellar sleeve brace. I'm trying to remember what Dr. Heemstra likes to use because she has one brand that she does like, but I can't remember it off the top of my head, to be honest. I can ask her though, and we can get back to you.
Dynatrack Patellar Stabilizer. Does that sound familiar?
Yep, that could be it. I know, I think she's got like two that she likes. I'm totally blanking on what the names are right now.
Dr. Heemstra is on the call. I don't know if you are listening right now, if you could jump on an answer. Breg.
Breg, that's it.
Breg, Sarah.
Thanks,
Thanks, Sarah. We have another question from Fabi on the chat. She's asking, is a TTT ever done in isolation?
I would say no. I know that they used to do that for sure. We've definitely seen patients come back with it, but now the standard would be to do the MPFL plus a TTO. That MPFL still needs to be reconstructed to provide more support on the medial side of the knee, and then the TTO would be in addition, if warranted. And even in the revision situation, let's say the patient had previously had an MPFL reconstruction, but no tibial tubercle osteotomy. In the revision situation, if now they were saying, you know what, you do have a reason to do that TTO, then we'll do a revision MPFL with the TTO.
Another question from Fabi. Any differences in the MPFL with TT rehab versus MPFL on its own?
Yeah, so the biggest difference, and this is a little bit surgeon dependent, I know Dr. Kopka and Dr. Heemstra do it slightly differently, but the brace will get locked. So Dr. Heemstra will lock the brace for 3 weeks and then reevaluate in clinic, whereas Dr. Kopka will probably only lock it for a couple days to a week. But in both situations, the patient is still weight bearing as tolerated. And then once we let them start ranging their knee, it's a very similar protocol. The difference is that the patient is in more pain. They've had more surgery, it's a bigger surgery. And so that definitely causes more discomfort for them in the long run. And it's just a bit of a slower recovery.
Another question. So I think this is from Barb saying that a previous talk that about 25 to 30% of the ACLs also had concurrent patellar dislocations. Are you still seeing that? Some of these showing up later.
I have not seen 20 to 30% with concomitant patellar instability with the ACLs. I think that number is a little bit high. That would be my feeling. I don't know what the literature is on it, but that seems high to me.
Hi, I have a question, if that's okay. Great talk,
Yeah, absolutely.
Dr. Marien. Thanks very much. I'm not sure if I missed, but did you go over your rehab protocol for a first-time dislocator for patellar instability?
I didn't actually. The main thing when it comes to first-time dislocators are regaining that range of motion, regaining any type of quad strength that they possibly can, and building up any quads that they were lacking before. And I think the other thing to always remember, and again, the physios are great at this, but is remembering that it's not just the knee, it's not just the knee muscles, it's also the glutes, it's the core. And if those muscles are not strong, then the knee can't be strong. And so focusing on the whole body rather than just focusing on the knee is super important. We do recommend a patellar stabilizing brace if they feel like they need it. But they can wean out of that as soon as they're starting to feel more comfortable. And really, at the end of the day, it's building up that strength to be able to try to keep the kneecap more balanced with the VMO firing and a little bit less lateral firing of the muscles. So a little bit more balance in terms of the muscles around the knee.
Great, thank you.
Oh, comment, just a comment, I think, from Sarah saying that we published a case series of 22 combined ACL plus MPFL, and now have around 30 of these cases that were symptomatic and needed both ligaments reconstructed.
Right, that makes sense. I just don't think it's up to 30%. That's what I was not sure about. Sarah would know way better than I would, though. She definitely has that data. Okay, it seems like there are not any more questions, so I will let you all go, but thank you very much for your time and thanks for joining us.
And thanks everyone for your questions as well. And thank you, Dr. Marien, for putting this on. It was a great talk.